In this video, we're going to talk about some pharmacologic principles, and in the following video, we'll talk about specific drugs and proper way of dosing. When you're dosing a drug, you must account for the volume of distribution, the VD, for administration of the loading dose, and the clearance for maintenance dose. Those are the most, if you're going to remember two things, you're going to remember those two. A drug that's mainly distributed to the lean tissue should have the loading dose calculated based on the lean body weight. If the drug is equally distributed between the adipose and the lean tissue, dosing should be calculated based on total body weight. For maintenance, a drug with similar clearance values in both obese and non-obese individual should have the maintenance dose calculated based on the lean body weight. But a drug whose clearance increases with obesity should have the maintenance dose calculated according to total body weight. As you can see in the figure, the relative volume of central compartment where drugs are first distributed remains unchanged in the obese patients, but absolute water content is decreased. Lean body and adipose tissue mass are increased, affecting the lipophilic and polar drug distribution. The volume of distribution in obese patients affected by multiple factors, including reduced total body water, increased total body fat, increased lean body mass, altered protein bonding, increased blood volume, increased cardiac output, increased blood concentration of the free fatty acid, triglyceride, cholesterol, and alpha-1 acid glycoprotein, lipophilicity of the drugs, and organomegaly. Increased distribution of a drug prolongs its elimination half-life, even when the clearance is unchanged or even increased. Hyperlipidemia and increased concentration of alpha-1 acid glycoprotein may affect protein binding, leading to reduction in the free drug concentration. Plasma albumin and total plasma protein concentrations and bindings are not significantly changed by obesity. But when compared with normal weight individuals, a relative increase in plasma protein binding may happen. Splanchnic blood flow, blood volume, and cardiac outputs are all increased in obese patients. In contrast to the expected decrease in bioavailability of the orally administered medication because of increased splanchnic blood flow, there is really no significant difference in absorption and bioavailability when comparing obese patients with normal weight patients. Drugs that undergo phase 1 metabolism, the oxidation, reduction, hydrolysis phase, they're generally unaffected by changes induced by obesity. But phase 2 reactions, the glucuronidation and sulfonations, are enhanced. Histologic abnormalities of the liver are common in the obese patients with concomitant deranged liver function tests, but drug clearance is typically not affected. Renal clearance of drugs is increased in obese patients because of increased renal blood flow and GFR. So, the increase in GFR and tubular secretion, drugs like cimetidine and aminoglycosides that depend on renal excretion may require increased dosing. The highly lipophilic drugs like barbiturates, benzodiazepines show significantly increased in volume of distribution for obese patients. These drugs have more selective distribution to fat stores and therefore a longer elimination half-life, but with comparable clearance values to normal individuals. Less lipophilic compounds have little or no change in volume of distribution with obesity. Exceptions to this rule include the highly lipophilic drug digoxin, procainamide, and remifentanil. Drugs with weak or moderate lipophilicity may be dosed on the basis of lean body weight. Adding 20% of the estimated ideal body weight dose of the hydrophilic medication is usually sufficient to include in the obese patient's to account for the obese patient's extra lean mass. Non-depolarizing muscle relaxant can be dosed in this manner too. Increased blood volume in the obese patient decreases plasma concentration of rapidly injected IV drugs. Fat, however, has poor blood flow, and doses calculated on actual body weight could lead to excessive plasma concentration. So calculating initial doses based on lean body weight with subsequent doses determined by the pharmacologic response to the initial dose is a reasonable approach. Repeated injections may accumulate in fat, leading to prolonged response because of the subsequent release from this large depot. Patients' usual medications should be continued until the day of surgery, with the possible exception of certain blood pressure medicine, insulin, and oral hypoglycemics. Antibiotic prophylaxis is usually indicated because of an increased incidence of wound infection in the obese patients. Anxiolysis, prophylaxis against aspiration pneumonitis, and DVT should be addressed preoperatively, as you know. Oral benzos are reliable for anxiolysis and sedation. IV benzos like midazolam can also be titrated in small doses for anxiolysis during the immediate pre-op period. Dexmedetomidine, because of its minimal respiratory depressant effect, should be considered. But don't forget dexmedetomidine, if you give too much, they get sleepy, and if they have sleep apnea, they're gonna obstruct. Pharmacologic intervention with H2 receptor antagonists, non-particular antacids, or PPIs will reduce the gastric volume, acidity, or both, so reducing the risk of severity of aspiration pneumonitis. So you should definitely think about using those if you have any suspicion of problems. I love this table because it's huge and it's not entirely accurate, but it kind of shows a picture of, with different drugs, what you should do in terms of dosing for the induction dose or maintenance dose if you're running an infusion. And in the next video, we'll talk more into details about